welcome back everybody to the Eyecare Experts. Today's topic is we're going through contact lenses in general, and more specifically patients who have corneal ectasia, which would be keratoconus and things like that. And Dr. Ballard is certainly joining us again. We're glad to have him back in this segment.
Glad to be back.
It's nice to have a Pensacola boy in with the program too.
It's changed a lot over the last 20 years, but still love it.
For the better. For the better. Yeah, for sure. Well, contact lenses. I've been wearing contact lenses personally since I was 13 or 14 years old, and I know to go from when I first started wearing them to where we are now, there's certainly a big change. As far as then, they were all conventional lenses that you would wear maybe for 3 months or 6 months or a year, and now we've gone to a more disposable, whether it's a monthly or a daily disposable, and they're healthier, they're more breathable, and we've got a lot more options.
The majority of lenses back 20 years ago were made of material that was wettable, so they were fairly comfortable, but they would kind of suffocate the cornea for oxygen. And when that happens over years and years and years, it can lead to vision loss, permanent vision loss. And so luckily, industry, especially in this country, tends to breed better products, so companies can stay competitive. And so we're working with a much better toolkit, I feel, for you guys. I mean, y'all get a sample and it would be different than what you prescribed, and now the task has become much more straightforward and safer, I think.
Well, one of your favorite, the materials certainly have gotten better. The more breathable, DK values have gotten higher, meaning more oxygen is going through that lens to the cornea so it can breathe. One of your favorite pictures, I think, to show to patients are the ones who are sleeping with them and overwearing them, and you show them the neo or vascularization of the cornea and things that can happen.
Yeah. And I do that with every patient so they know what the risks and benefits are for doing this. And many people say, well, I had no idea of doing it. And that takes time, and it takes, it's just good care of the patient. But the reason for the increased repeatability of these lenses is that they're robotically made, and computer engineers have written algorithms that can make these things 99.9% of the time exactly what you order. So the mechanics have changed, and the patients appreciate that, and they know that.
Yeah, and it's exceedingly frustrating as a practitioner if you on paper it makes sense, right? And if you order a product and it doesn't work, it's not good for anybody. And so luckily the technology has improved, and we can fit a lot more people into contact lenses than was ever possible.
That's correct.
Well, just talking with soft lenses for a second here, as far as soft lenses, I mean, we have sphericals, we have ones that correct for astigmatism, we have multifocals. A lot of patients will say, hey, can I wear contact lenses? I'm in a progressive, I'm in a bifocal. And most of the cases, those patients could, as far as wear a multifocal, whether it's a monovision. I know you do a lot of monovision, one eye distance, one eye near, but they even make multifocal torics too. So within soft lenses, they have come a long way through the years.
And there's more coming.
Yep,
yeah.
More coming.
Every couple of years, a new lens hits.
Johnson & Johnson spent a ton of money on the new drug-eluting contact lenses. And so these drugs that patients have to put in time and again will be dispensed by the lens, and it will give it in a time-release fashion. And so the effect of the drug will last longer, be better, more effective, and that's going to be and that's coming perhaps the end of 2024 and certainly in 2025.
That makes me think of some movies like Mission Impossible movies and stuff I've seen where, it was like a camera with a contact lens, and some of the stuff is not as far-fetched as you think. To think that you can have a contact lens that helps distribute what you need.
Right.
And that is unbelievable.
Yeah, there's a variation on Alcon where their lens will measure your sugar level. So in addition to the one that you can have inside your arm, which is a surgical procedure, but it's relatively safe. But this one, you just wear your lens, and it would do it for you and transmit it to your phone.
Yeah.
I mean, that's crazy.
So that is.
Yeah, that is a little ways away potentially, right?
Yeah,
so we're not, doing those in the office, right?
Yeah.
Well, one specific one we want to talk about is keratoconus, and I want you to kind of certainly go down and define it. But we get patients a lot who say, you know, I have astigmatism. Well, what is astigmatism? Let me start with that. Astigmatism in general has to do with the front shape or curvature of the eye, the cornea. And so with kids, I'll say it's not like a baseball, it's more like the edge of a football, but either way, you know, when you look at things, it's blurry, you tend to squint because you have the astigmatism. So astigmatism has to do with the front shape of the eye, but keratoconus is...
Yeah, so astigmatism, like Dr. Bell said, is you know, steeper in one direction than the other, but they're 90 degrees away from each other. So it's very predictable. You know, that's why soft lenses work for it. You know, if you need this strength here and this strength here, you line it up, boom, you can see. But with other corneal conditions, probably most commonly keratoconus, the cornea becomes irregular. So that astigmatism, instead of being in two directions, is now a big blur of craziness. And what's difficult is that glasses aren't effective after a certain point. Because even if Dr. Teresa got your prescription perfect, if it's going through the eye irregularly, you may have reduced vision, a lot of glare, light sensitivity, even though you're wearing your correct prescription. And so, did you want to talk a little bit about what?
Let's go through.
Watch out for what risk.
Well, you know, as far as keratoconus in general, you know, there's different levels, I guess I would say. In the early stages, you know, glasses. You know, it gets to the point where you can't see well with glasses. Then we usually can move to maybe like a hard lens. We say like a rigid gas permeable lens. And the reason oftentimes you can see better through that is because that hard lens presses on the cornea. We already talked about the steepening of the cornea. And if you have a lens that flattens it, that can get the patients to see better. And that's the reason a lot of times with contact lenses, with keratoconus and high astigmatism, they can see better with contacts than glasses. Because glasses, the spectacle plane is out here, it's not affecting or sitting on the cornea, but those hard lenses are. And so you have RGPs. Nowadays you have hybrid lenses where it's a hard lens in the middle, but a soft lens skirted around that. So that's a hybrid lens. And now you've got sclerals, mini sclerals. We have so many options to fit patients with nowadays.
And they're all custom. You know, unlike a lens you buy off from our office off the stock shelf or at Walgreens or whatever, these lenses, due to a corneal condition, are custom made by us with consultants with our labs that we use. And Dr. Teresa just purchased a piece of equipment that has made this task much easier. Do you want to bring
I
that
do.
up?
It's made by a company in Australia called Medmont. We're the only ones with one in the area. And this thing will plot the front of the eye with 5,000 points. In addition to that, you can look at it in 3D form, and you can put a dye in and put a trial lens on, and this will simulate what that thing is doing on the eye. Then you can change it virtually and come up with alternatives without having to order a lens, come back, put that lens on, see how it works, send it off, get another one. This speeds this up tremendously. In addition to looking at the glands on the front of the eye, in addition to being able to take external photos of the eye with those conditions there. So you have it documented.
Right.
Yeah, it's great.
I mean, I've tried it a few times. We just got it, and it's far superior to any fitting method I've trained on. Because yeah, you can get it right with trial and error and modification, but you're talking multiple times out of your day coming in and letting us tweak it, and multiple weeks to change it. So this speeds it up for us and you.
It's more accurate.
And it's more accurate.
Yeah.
And the more information we can gather on any individual, usually the better. You know, we can get them fit initially, get the vision done. You're too young for this, but when we first started out, you know, we'd try to get topos, we try to get Ks, but some patients, the Ks were so steep we couldn't get them. And we'd call in to, one of these companies and order the, specialty contact lenses. And you were talking, 15, 20, 30 years ago, they'd be way off. But I mean, we'd put them on there and we'd do maybe an overfraction if we could. And then we go to we go to round 2 or round 3 or round 4 to get it to work. But nowadays, we can't guarantee it. We can get on the first try, but I guarantee you within 2 or 3 tries, we'll get you fit as good as we can as far as vision-wise, comfort-wise, and figure out what's going to best work for you.
Well, last year, the American Academy of Eye Surgeons did a study where the incidence of this disease prior to this was 1 in 10,000. They're talking estimates now of 1 in 300 people.
We're talking about keratoconus now. Talking about keratoconus.
The disease.
I believe it.
And that's a tremendous, that shows how far off, and that was years of research on that, and they missed the bus. And so did optometrists.
Yeah.
We're equally as guilty. But it was a question of not having enough knowledge and enough accurate equipment to really measure what this thing was doing, so people just lived with it. Well, those days are gone, okay? And certainly the instruments out now can detect that. They're expensive, but you can detect it and fix it. And that's a big plus.
We've had this discussion before. The great thing about technology and equipment is we're getting so good at, as far as picking up things at an earlier stage, as far as diagnosing certain conditions at such an early stage compared to what we could, 10 years ago, that, the diagnosis is there, but sometimes the treatment is not there yet. So the treatment's going to come here very shortly because we're able to pick up so many things so early. There's going to have to be a better treatment to say, hey, you picked this up at stage 1. Right. What do we do treatment-wise versus stage 4 where we usually pick it up?
Always easier to prevent and treat early than it is cleaning up a mess on the back end. And it's the healthcare system doesn't always reward that here, but it's a fact.
It's changing.
It's changing. And so if I was, what would be some of the signs and what's a typical demographic of someone with keratoconus? What would you say?
Well, I usually, a few things I'm looking at. This won't probably be everything on there, but I always ask parents, do they rub their eyes? Or are they one of the kids that kind of put those hands and they're just, rubbing the eyes all the time as far as the lid's really hard? I usually, if I can, look at past prescriptions. Has their astigmatism been going up? Has it been changing a bunch? Because most of the time, with most people, astigmatism is pretty stable. There's really not that much change as you get older. There may be some change as far as nearsighted, farsighted, but if your astigmatism is changing that much year to year, there's something that's causing it to change. Right. And one of the things at the top of that list to eliminate would be keratoconus.
And what would you say is the typical age range? From what I see clinically and based on the research, it seems to be almost kind of fairly characteristic patient. They come in, they are probably already wearing glasses, they're young adults, late teens, early 20s, and they'll just say, hey, I see okay with my glasses or my regular contacts, but it's just not great, and then you do your exam and you go, you're right, it's not great. We're getting okay vision, but just not great. And we got to figure out why. We're not going to cut you a prescription for glasses and not figure out why an otherwise healthy 20-year-old can't see 20/20.
What you've hit on now is the differentiation between a truly independent clinic that doesn't stop there, write the script, and move on, associated with a company whose financial model is based on the sale of the glasses. If in fact the patient is the center of attention, then you look into the why of that eye is not seeing well. And that's the key. That takes equipment, that takes time, and the doctor has to give a hoot about what he's doing.
Right. Yeah, that is the big thing for me is I was trained if you cannot get an otherwise healthy person to 20/20, you need a reason. You need a reason.
And you've got to go through. When we have a patient who calls up and says, "Hey, I can't see. I can't see as well. I'm blurry." Well, that could be because your prescription changed. We're going to check that. It could be, you have keratoconus and glasses is not working for you anymore. Right. It could be corneal edema. It could be cataract. It could be so many things that a lot of times people just assume that it's always the glasses' fault. My glasses changed. Right. Are you diabetic? Did your blood sugar change? How old are you? Do you have cataracts? There's so many things on that list, and it takes time. If we're not going through and looking at everything, and that's the reason we like to dilate you and check everything in the eyes, is that way at the end of all that, we can give you a reason, most often not, of why you're not seeing good, or what will make you see better.
That's the definition of a good eye exam, right there.
I don't know how you could just check the glasses and that's all you check and say, hey, this is the best I can see you tomorrow, without checking all the other stuff.
Right. It could
there is an ethical problem with that, but the public has gotten used to that and they can live with that, but that's not right.
Yeah, and believe it or not, guys, the eye is attached to the body, right? Some people tend to forget that. Yes, it's a little unique. The systems are a little more independent as far as, immune response and things like that. But it's attached to the rest of you. So if sometimes we find stuff first in the eye, and it could lead to knowledge about your systemic health. And we're a lot easier to go to than going and getting a full workup and imaging and this and that. So it's a good starting point if you're interested in your health a little bit more.
Particularly in symptoms like headaches.
Yeah.
So when someone has a headache, it turns out that 30 to 40% of them are visual in nature or visual in cause. So it would be good to do that initially as opposed to after you've had full neurological and everything else. Just a question of primary care. Gets checked first, then goes to secondary, then goes to tertiary.
Yeah, and I know we got off topic a little with
Keratoconus,
that's fine. But I typically see I guess a little bit of a younger population, and I agree with that number you said. You said what, 1 in 300?
Yep.
That seems about right, and that surprised me. I thought it was something about this area or something like that. But I think that condition is important to diagnose in young adulthood because we're talking working age, prime of their life people, okay? And not that everyone isn't important, but if you have 2 kids running around and you're working a full-time job and you can't see and you don't know why, we got to fix that, and some of these are preventative measures too. Like corneal cross.
Yeah, we hadn't gotten to the surgery stuff, but it used to be it would get so bad everybody would just you could be a corneal transplant. But there's so many better options nowadays before we ever get to the point where we have to do something serious like that with cross-linking.
Catch them early enough, you can even avoid those drastic procedures.
For sure.
That have problems with host rejection and everything else, and you're getting fairly bizarre with that.
Yeah, the worst failure currently is needing a corneal transplant. That's the worst thing that could happen with keratoconus. And the fact that we have better and better technologies to prevent that from ever happening is great. You just got to let us try,
This reminds me of the eye accident thing, the big thing like July 4th coming up.
Oh, yeah.
And people, the number one thing is fireworks, and they tend to hit the eye. Well, 98% of that is preventable. It's called safety eyeglasses and watching what you're doing with the fireworks.
So you mean this doesn't count? You can't just squint and hope it doesn't hit you?
No.
Okay.
No.
Well,
I see people weed whacking.
Well, come in to see us. Certainly if you want to wear contacts, if you've been told you can't wear contact lenses, if you're having astigmatism, if you're seeing blurry and you don't know why, or your glasses are just not working for whatever reason, let us look at it. We've got all the equipment pretty much at all of our offices. We can kind of figure out things and let you know kind of what's going on. And to all what we've said is earlier we catch things and diagnose things, usually the better the outcome is for you and the less severe it gets. And we all want to see well, right? We all want to see the best we can.
And even if we can't fix it, we know the lay of the land. I mean, we know who's the best in the area for certain conditions. I mean, so even if we can get a good evaluation, a baseline, and then direct you into the right specialist if we have to, that's valuable.
For sure.
And it saves you a lot of copays and time,
Well, let's get into one question. Certainly some of the patients are asking us. First question is, can we use, and I'll apply this to all drops, but the specific is, can we use red eye drops if we wear contact lenses? Anybody want to take that as far as just drops and contact lenses in general?
Hold your horses here. Why are you getting the red eye? What's the cause of that? And once you establish that, then using drops. However, I have to tell you, if you're using over-the-counter drops now, there's a national lawsuit that's been on the news about not using them, and there's a great lawsuit going to occur in the next 2 to 3 years, which will stop the big boys in the big box retailers, including Walmart and Walgreens and CVS, Family Dollar. The list goes Target. The list goes on and on. So you have to be careful about what you're putting in there. Yeah. And now you're putting drops in because you don't know the etiology or the cause of that redness, and that's shaky too.
Yeah.
And some of the drops, the vasoconstrictor, get the red out, can actually end up causing redness, where it's kind of a cycle where you're using the drops and it never gets better and it gets worse. But to your point, we want to find out. Come in, let's figure out, why do you have red eyes? Is it allergies? Are you maybe wearing the contacts? Are you sleeping with them too much? Or you just have red eyes?
Or it could not be fitting. The contact could be fitting incorrectly. We need to steepen it, flatten it. There's
Change
a lot
the
of
size.
change the size, change the material, change your solution.
Or breathable lens. There's a lot of options out there.
But I guess short answer, yeah. I mean, if you don't want to know the cause, anything preservative-free you can generally use that's non-medicated, like an artificial tear.
If you're going to do that, why not just put duct tape on it?
Exactly. You're just you're band-aiding a problem. You're not fixing it.
So come in to see us. We certainly want to get you, those days of just going and trying to drop and just putting it in there, hopefully that's coming to an end where, we want to see exactly what you need, get you what's going to work versus you just trying something and quite often it not working. But we would certainly want to thank Dr. Blard again for joining us for this segment. We've had fun today and appreciate everybody viewing. Thank you guys for liking. Certainly keep the questions coming. Any topics you want to hear about, any specific questions, any eye-related conditions, we want to hear you. So thank you very much again for tuning in.
Great. Thank you.